Welcome to Caring for Patients with Nasal Polyps in 2023, When to Consider a Biologic or Surgery, presented by the Global Education Group in collaboration with the Asthma and Allergy Foundation of America and broadcast simultaneously in Immunology Live and Res Insights Live. This is the third module in this four-part series and is titled Inflammatory Pathways Involved in Nasal Polyp Formation, Beyond Local Inflammation. My name is Dr. Katie Buchheit. I'm an associate physician at Brigham and Women's Hospital and an assistant professor at Harvard Medical School. Today's session is interactive, allowing us to take your questions in real time throughout this presentation. We encourage you to enter questions at any time in the box below. I'd now like to introduce Dr. Stella Lee, Director of the Brigham Sinus Center at Brigham and Women's Hospital. Dr. Lee will be joining me for our Q&A at the end of the session. Thank you, Stella, for joining me today. Let's get started. These are our disclosures.
These are our learning objectives for the series. We will summarize the burden of disease and treatment for patients with nasal polyps with a focus on outcomes that matter most to patients, such as the ability to smell, sleep, and be productive. Describe the type 2 inflammatory relationships between nasal polyps and common comorbidities such as asthma and aspirin sensitivity, AERD, or NSAID hypersensitivity, or NERD. Explain how enhanced knowledge of nasal polyp endotypes and type 2 inflammatory pathways can guide treatment decisions. And finally, review recent recommendations for the management of nasal polyps with surgery and/or monoclonal antibody therapy, especially as they apply to the management of uncontrolled severe nasal polyps.
So this is Module 3, Inflammatory Pathways Involved in Nasal Polyp Formation, the Role of Inflammatory Phenotypes, which is really important to understand as we think about the appropriate treatments to select for our patients with nasal polyps. So this figure is from a multi-center case control study that was done in Europe, including actually hundreds of patients with nasal polyposis, where tissue studies were done from surgically excised nasal polyp tissue, looking at a variety of important inflammatory mediators. And what we see here is that in patients with more of a type 2 endotype, meaning the patients who are interleukin-5 positive, shown in the dark maroon in the columns, who also had higher IgE, higher eosinophil markers such as eosinophilic cationic protein markers, they were much more likely than the patients with without these T2 markers to have nasal polyposis, and they were much more likely to have asthma. The patients who were low T2 were more likely to have chronic rhinosinusitis without nasal polyps, and they were much less likely to have asthma. So, what they were able to do is take these unsupervised inflammatory clusters and associate them with clinical phenotypes. This next study is another study looking at surgically excised sinus tissue and important inflammatory markers in the tissue. So in this particular study, sinus tissue was surgically excised from healthy controls from their ethmoids, from patients with chronic rhinosinusitis without nasal polyps, chronic rhinosinusitis with nasal polyps ethmoid tissue, and then actual polyp tissue. And looking at what are considered to be these classic type 1 inflammatory mediators, interferon gamma, we see that there's really actually no difference in interferon gamma levels between all the different tissue types that were tested. In the middle panel, they measured eosinophilic cationic protein, which is a very classic type 2 marker and associated with eosinophilia. And here we see that the nasal polyp tissue itself had the highest levels of eosinophilic cationic protein, as did the ethmoid tissue from patients with nasal polyps. Eosinophilic cationic protein levels were much lower in the control tissue and also the tissue from patients who had chronic rhinosinusitis without nasal polyps. And then in the figure on the right, the classic type 3 marker, IL-17, was measured. And this is actually significantly higher in the ethmoid tissue from patients with chronic rhinosinusitis without nasal polyps compared to the control ethmoid tissue, indicating, that type 3 inflammation may be driving the inflammatory profile of some patients with chronic rhinosinusitis without nasal polyps. It was slightly elevated actually in the polyp tissue, certainly compared to the control tissue, although it was not statistically significant. Looking further at inflammatory profiles from nasal polyp tissue in patients in a Chicago cohort, on the pie chart here in the left, we see that in this Chicago cohort of patients where they had their nasal polyp tissue endotyped, looking at markers of type 1, type 2, and type 3 inflammation, about 87% of the patients had some sort of type 2 inflammation. So the majority of patients in the pie chart were in red. They had really pure type 2 inflammation, but there were a variety of patients who had mixed type 1 and type 2 inflammation or type 2 and type 3 inflammation. This is very common for what we see in the United States and Europe. However, in other parts of the world, type 2 inflammation is not always the predominant endotype. So on the right, we see in these bars, a study that was done in Chengdu, China, shows actually only about 20% of the patients in their CRS cohort had type 2 inflammation. Many patients fell into an untypable category, meaning that they didn't fit into any of the three categories we typically think of that most of the patients that we see in the US fit into. This is data from a study that was done again at multiple regions of the world. And we see that in the bottom bars, that represents the patients with chronic rhinosinusitis with nasal polyps. In Europe, Berlin and then Australia and Adelaide, most patients have eosinophilic chronic rhinosinusitis with nasal polyps, but that's different in Beijing and Chengdu. So really there are regional differences that certainly may reflect genetic, environmental, and dietary factors. So moving on in terms of sort of what is going on in terms of immunity in these type 2 responses for nasal polyps. This is important to think through and understand for two reasons. One, as we talked about in an earlier module, patients with nasal polyps have high risk of recurrent disease after sinus surgery. And that's because this is really an immunologic problem, an inflammatory disease. Two, it's important to understand this as we're selecting many of the newer available treatment options for our patients with chronic rhinosinusitis with nasal polyps. So here in this schematic, and there are many that look like it, and we'll look at another one briefly, we see that there's likely some sort of immune insult that can impact the airway epithelial cells, so the sinus tissue epithelial cells, to produce alarmin cytokines, such as thymic stromal lymphopoietin, interleukin 33, sometimes IL-5 has been measured as being elevated. And these innate type 2 cytokines can go on to impact a variety of different immune cells, such as ILC2s. They can cause T cell polarization to Th2 cells, certainly have impacts on dendritic cells, to then produce further inflammatory mediators that propagate the inflammation that we see in the sinus tissue, such as IL-5, IL-4, IL-13. Leading to recruitment of additional inflammatory cells in the nasal polyp tissue and leading to further dysregulation of the nasal tissue epithelium. This slide is actually a very similar schematic. It's slightly more complex, but again, shows how we think a lot of the dysregulation likely originates in the epithelial cells themselves. The sinus tissue epithelium is exposed to many pathogens, environmental factors, allergens, infections, insults, and things. And when it is impacted, it again can produce alarmin type cytokines, which can go on to propagate significant downstream regulation, downstream inflammation, production of IL-4 and IL-13, which has known impacts on B cells, leading to differentiation of B cells and plasma cells to become IgE producing cells, which then can go on to activate mast cells and basophils, which are known to produce a variety of downstream inflammatory mediators. IL-5 levels, as we talked about earlier, are elevated in the nasal polyp tissue, and that can lead to differentiation, activation, proliferation of eosinophils, which widely infiltrate the tissue in nasal polyposis. We also think that there is a potential important role for B cells in producing other immunoglobulin isotypes and potentially even autoantibodies, which then can lead to complement-mediated epithelial damage as well. So there is a lot of complexity in terms of the inflammation in type 2 chronic rhinosinusitis with nasal polyps, and we're really just beginning to understand it and scratch the surface. But it's important to think through about why this is occurring when we're selecting appropriate biologic agents that can target these inflammatory mediators. So the mechanisms of non-type 2 chronic rhinosinusitis with nasal polyps are, also fascinating, and we're just really beginning to, I think, scratch the surface in understanding this. But, through some slightly different mechanisms, we think that the most important cytokines that can drive this type 2 inflammation are non-type 2 inflammation are interferon gamma and IL-17. Which can, again, go on to propagate neutrophilic inflammation, production of oncostatin M, which is an important player in chronic rhinosinusitis with nasal polyps and may lead to additional epithelial barrier damage, can also lead to complement activation and additional tissue damage through that. So the mechanisms of non-type 2 inflammation are different than what we see in patients with type 2 inflammation. And at this time, there is, less available medications to target this type of inflammation, but currently an area of active research. Importantly, the inflammatory endotypes that we see in chronic rhinosinusitis do have some clinical prognostic importance and relevance. So type 1 inflammation, like I said earlier, it's associated with interferon gamma. Patients who have that type of inflammation often have purulent nasal drainage. In our patients with type 2 inflammation, which again is what we see most commonly in patients with chronic rhinosinusitis with nasal polyps in the US, those patients are more likely to have comorbid asthma and are likely to have smell loss associated with this. They're less likely to have cough or pus like we see in patients with type 1 and actually type 3 inflammation, which is commonly thought to be driven at least in part by IL-17. Those patients, like the patients with type 1 disease, have purulent nasal drainage as well. And when we think about the comorbidities that we've seen in patients with type 2 inflammation, there's a lot of common factors driving chronic rhinosinusitis with nasal polyps, but also the comorbid asthma and atopic dermatitis that we see in these patients as well. And this is just a closer look at odds ratios of clinical symptoms for patients with different chronic rhinosinusitis endotypes. We see that, as I showed earlier, patients with type 2 inflammation are much more likely to have smell loss than patients with type 1 or type 3 inflammation. But interestingly, patients with type 2 inflammation are much less likely to have intraoperative pus compared to patients with type 1 or type 3 inflammation. So there's some really important clinical correlates and things to think about when we're evaluating patients with chronic rhinosinusitis and thinking about what sort of inflammatory endotype might be driving their disease. So I'm showing this because AERD is thought to be really a classically very high T2 disease. These patients have a lot of tissue and peripheral blood eosinophils. They're known to have high tissue IgE levels. But even within AERD, distinct inflammatory clusters have been identified. So this was a cluster analysis done by Justin Turner's group at Vanderbilt, where they showed that patients who had AERD could be classified in unsupervised clustering algorithms into patients with a low inflammatory burden, low inflammatory markers overall, T2 high patients who had high levels of IL-4, IL-5, and IL-13, or a T1, T3 high inflammatory cluster, patients with high levels of interleukin-17 or interferon gamma. So there may be some inflammatory heterogeneity within AERD. Interestingly, they did a clinical follow-up analysis of these patients and actually found that the patients who were in the cluster 3, so the T1, T3 high cluster, they had the highest risk of nasal polyp recurrence after having endoscopic sinus surgery compared to the patients in the T2 cluster or the patients in the low inflammatory burden cluster. And they were also more likely to need oral steroids, both the patients in the T2 cluster as well as the patients in the T1, T3 high inflammatory cluster compared to the low inflammatory burden cluster. So, we think that actually endotyping patients, even within what are classically considered to be T2 high diseases, may be important prognostically. It's been known for some time that IgE levels are elevated in patients with chronic rhinosinusitis with nasal polyps. So here on the left is data from a study that was actually done back in 2004, showing that patients who had nasal polyps and aspirin sensitivity on the far right had the highest tissue IgE concentration. In the figure the two figures on the right, we showed that patients with AERD had the highest tissue IgE concentration compared to nasal polyp tissue from patients with chronic rhinosinusitis without nasal polyps, chronic rhinosinusitis with nasal polyps, and non-CRS controls. And that within the AERD population, patients who reported the fastest nasal polyp recurrence after surgery had even higher tissue IgE levels. So this may be important from a prognostic standpoint. And then lastly, I'm going to finish up with a recent study where patients were clustered into 5 different inflammatory clusters. Cluster 1 and cluster 2 were the non-T2 clusters. And then clusters 3, 4, and 5 had either really predominant neutrophilic or eosinophilic inflammation. This study was done including 128 patients with chronic rhinosinusitis from China, as well as some controls. And I just want to point out that the patients who are in the T2 clusters and sort of the neutrophilic and eosinophilic inflammatory clusters, clusters 3, 4, and 5, they were much more likely to have comorbid allergy. They're more likely to have anosmia. They're more likely to have nasal polyp recurrence after surgery, and they had worsened sinus CT scores. So again, these inflammatory clusters really do, I think, predict some prognostic information. And I just want to briefly show this, that again, there are likely treatment limitations for patients with non-T2 chronic rhinosinusitis with nasal polyps. Currently, there's no approved biologics for these patients, where there are multiple biologics available for patients with type 2 inflammation. And we're going to talk about that more with our next module when we focus more on treatment. So to summarize, chronic rhinosinusitis with nasal polyps has distinct endotypes and phenotypes, and we see actually really important geographic differences in CRS endotypes, with type 2 inflammation being predominant in the United States and Europe. Chronic rhinosinusitis with nasal polyps in patients who have type 2 inflammation is characterized by high levels of IL-4, IL-13, IL-5, tissue IgE, tissue eosinophilia, nasal polyposis, and asthma comorbidity. And chronic rhinosinusitis with nasal polyps, the specific endotypes are associated with special clinical features. So patients who have T1 and T3 endotypes, this is more frequently associated with purulent nasal discharge, intraoperative pus, whereas patients with a type 2 endotype often have associated anosmia or comorbid asthma. So we'll move on to Q&A, and I think that Dr. Lee is going to join me again, and we have a few questions coming in from the audience. So thank you for your questions. Stella, I think that this is actually a great question for you. How often does an individual patient typically need to undergo surgery for nasal polyposis? And how do you kind of think about the inflammatory endotype when you're selecting a patient for surgery?
Thanks, Katie, for that question. It's complicated, but I think with all of this new information that we have, it doesn't have to be. We are learning that, patient-specific factors, as you mentioned, are very important. So not everyone fits into a particular clean category, perhaps. So in my practice and looking at the data as well, I think it's important to not just have one visit with the patient, but to really truly understand the patient. You need to follow that patient over time, and to really take a great history, assess comorbidities, as we talked about, but also understand patient preferences too, because some patients you will go to do a nasal endoscopy, which we commonly do as otolaryngologists, and it's just not the most pleasant experience, or they just do not want to spray their nose. They don't want anything in their nose. And some patients are fine with that. And then other patients are maybe needle phobic, so they don't want to have, perhaps had a horrible experience with allergen immunotherapy, so they might not be a great biologic candidate. But I think in general, just having that understanding of the patient and what endotype the patient falls into, but also the patient preferences, what their environmental factors are. I think it's so important to really assess the entire patient as a whole. And then when we have the discussion about treatment options, the patients who really opt for surgery, I think it's the most important thing is that surgery is not a cure. We don't have a cure for this condition. This is a quality of life condition. And so it's really important that, we can do the most meticulous surgery, but the post-operative care is just as important, including topical nasal steroids and saline rinses and all of those things. So it's a long discussion, and it's not just, can't be done at just one visit. And we always try to treat with medical therapy and pharmacotherapy, and appropriate medical therapy, whatever that means, right? We are still trying to define that before we decide on surgery.
Awesome. That's super helpful. It is certainly complicated, and it's great to, I think, be able to partner with our brilliant otolaryngologists to help with these discussions. Another question that came in that I think is really important is, are there labs I should be doing to endotype patients to guide treatment? So I would love to hear what you do in your practice, Stella, and I'm happy to weigh on it as well.
Sure. As you mentioned, eosinophils, we have that readily available with like a CBC with differential. So I think that's something that, that can give us some information. It's not giving us local eosinophils. We can only get that when we actually get tissue from patients during surgery, or if they're part of a research study. I think allergy testing, especially if they have a clinical history of allergic rhinitis, is really helpful to understand whether it's playing a role in the inflammatory process and the symptomatology, but also the role of IgE too. So those are the basic things that are available, like a CBC with differential and a serum IgE level. Curious what you do and what you think is important.
Yeah, no, I think I take a very similar approach. One important thing that I try to do, if it's possible, is when I, initially refer to patient with chronic rhinosinusitis with nasal polyps, or when I meet a patient, before starting any treatment, even oral steroids or a biologic, I'll often try to capture their serum IgE level and peripheral blood eosinophil level, because that can be very important in terms of limitations for selecting future treatments. As it's well known that oral corticosteroids can impact eosinophils in the tissues as well as in the blood. So if we're thinking about, a drug that may target eosinophils in the future, it can be hard to decide on that if we don't know upfront. So I like to do that as soon as I initially meet a patient where I think that they're going to need, some pretty intensive interventions for management of their nasal polyps. That's
One
great.
other thing I wanted to mention is that if there's any concern for like a vasculitis, if the nasal lining is there's a history of epistaxis or nasal pain, and then the lining looks abnormal, it is helpful to send an ankle level and think about eosinophilic granulomatosis with polyangiitis or other granulomatous disorders. You definitely don't want to miss that, and that can sometimes mimic CRS with NP.
Yeah, no, that's a really important point. That's something that I think is important not to be missed, because can certainly have lots of other systemic consequences for the patient as well. Great. Thank you so much, Dr. Lee, and thank you to our audience for the great questions. I'd also like to thank Regeneron Pharmaceuticals and Sanofi for the support of this important educational activity. Please remember to complete your post-test at the end of the session to secure your CME credits. Please visit immunologylive.com and resinsightslive.com to view today's session along with other sessions on demand. Stay tuned for the next session titled Treatment Pathways for Nasal Polyps. My name is Dr. Katie Buchheit. Thank you for joining us.